A patient of mine, sir, came to me and said, BMI was 40. And she said, is it easier to lose 30 kilos with very, very rigid regimen, or easier to gain 10 kilos and qualify for bariatric surgery? What is the role of bariatric surgery?
Of course, see, bariatric surgery is very important, but I must tell you one thing, that for somebody who is 100 kilo, for that person to gain 10 kilos is very difficult.
Okay.
No, it's not easy. There is a set point weight for most of these obese people. Only the static, unfortunately, high. But there is static. It's not gone all totally haywire. So whenever they lose weight, you'll be surprised when they gain back, they come to the same level. So that's their static. Of course, bariatric surgery is wonderful. I hope there are some bariatric surgeons here in your association. Bariatric surgeon? Okay. I won't say very unkind word, I'll just tell you the truth. Bariatric surgery, very good. I have some good friends, bariatric surgeons, and we did a meeting on obesity last year. Dr.H.B.Chandalia is here. I did a whole scientific program, so bariatric surgery was one parallel session we kept, and our surgeons had very good time, and then they interacted with us. So the main question I asked them is, what kind of patient shall I refer to you? For cure of diabetes and of course cure of obesity. And it said that send me a patient who just diagnosed, who will of course be overweight, and whose C-peptide, that is the endogenous insulin secretion, is reasonably intact. I said, I'm not going to send you that patient because that patient is very easy to treat with 5 kilometer walk and 1 tablet of metformin. So there is no reason that person will submit to this surgery. Can I send you a diabetic type 2, a bit overweight, like BMI of 30 maybe, and I exhibited 3 kind of triple drug oral therapy, then I introduced insulin therapy, still the A1C is not very good, still is hovering around 8, 8.5. Can I send you that? He said, no, I can't treat that. Then I don't get good results. So at the moment, bariatric surgery as it is being advocated, the plan falls between the two stools. It does not work greatly. Another thing I want to tell you why I would not send a lot of my patients for this. Of course, a gross obese person, yes, one who can't breathe, can't walk, can't talk, weekend diet, of course you'll send it for bariatric surgery. Gross overweight, not for diet, obesity. Gross obese, yes. But apart from that, I would not send, because all the harmful effects of obesity start actually receding as soon as you introduce a diet and exercise therapy. Means a 100 kilo person doesn't have to lose 20 kilos in order to restore his insulin sensitivity or lower his blood pressure or lower his blood glucose or lower his lipids. But when he starts doing it within a week or so, you see the beneficial effects. So it is not reaching the target, but it is the question of doing it and continue doing it, it gives you benefit. So in Bollywood language, it is not the manjil, but it is the suffer, which itself helps you. And you really don't have to lose, like bariatric surgery will make you lose from 100 kilo to 60 kilo. You don't have to do that. It is just not required. You lose 10 kilos or 15 kilos and maintain it, you get all the benefits. If you don't lose weight, also keep doing it, you get the benefits. So I really think that bariatric surgery is obviously overrated. They are extremely active people, they are very media savvy people, so that they keep writing in newspapers, excellent articles. And of course, as you know, in our profession, we don't try to counter any colleagues or anybody, so we keep quiet.
Okay. So, as we said, impaired fasting glucose and impaired glucose tolerance are loosely called pre-diabetes. Should we treat it pharmacologically?
Not necessarily pharmacologically, but you should treat them by definite lifestyle intervention. Because now we know that the complications of diabetes really start almost at that stage. It's not even when they are impaired, even before that. So in fact, our prevention studies have not given us as good results because they are also being addressed to this impaired glucose tolerance group. Now we think that we should be prior to that. So I think we should, but I think pharmacotherapy, I would not. There is one reason for that. When you practice prevention, the mode of treatment that you use has to be totally above board and free of side effects. Because a certain number of those people are not likely to develop the disease even on the natural course. Out of 100, there will be probably 20 or 30 who are genetically protected, and although you see that value, they will really never go into diabetes. So you have exposed them unnecessarily to the drug for a very long time. So remember, the prevention, whatever you use, has to be extremely simple mode of treatment, almost devoid of side effects. So I would not use pharmacotherapy very early on.
When I was in college, we used to be taught, and Harrison had that, the textbook had that recommendation, that even if you had overt diabetes, 126 plus fasting and 200 plus sugar, for the first few months they would say lifestyle changes, then repeat the sugar and then start it. Has that changed? Do we immediately start drugs if, by definition, patient is detected to have diabetes?
Yeah, I think nowadays, see, what has happened is, for example, UKPDS study, where there was definite design of study, a factorial design. So you use a lifestyle, then 1 drug, 2 drugs, 3 drugs. It's an excellent design. There, they had to, for study purposes, they did that. And the number of percent of people who control only diet exercise were only 10%. All the remaining, they had to then go on adding one drug. So ultimately, this number is small. Although I don't want to minimize the importance of lifestyle intervention. It has to continue in all. Every diabetic has to have that, besides whatever other therapy. But that being monotherapy, it does not work as well. So nowadays, when fasting blood glucose is very high, even initially we do not want to give a trial of only lifestyle intervention, because there are osmotic symptoms, patient is uncomfortable. When it is above 200 fasting blood glucose, most of us introduce, beside lifestyle intervention, 1 drug, and of course the first drug is metformin. So we do introduce that. We are on the lookout that if the person is obese and loses weight after 3 or 6 months, to remove that drug. But I think to produce initially response, one can straight introduce a drug. I don't think it is the wrong approach.
I think this is one important answer to many patients' question. When the patient asks you, which is one reason why they don't want to start at all, you can tell them that with lifestyle modification, if your sugars come back to normal, we have a chance of withdrawing a small dose of the drug.